All right, can you all see the screen?
Yes, sir.
All right, so what I've been asked to do is talk about pediatric emergencies, and I apologize if you hear my phone buzzing in the background. There's a NICU baby that I have to unexpectedly XLAP. I'm not on call. I wasn't planning on it, so we may end a little bit early so I can get over there. But I wanted to talk to you mostly about things that you'll see that are pertinent to you, and if there are any conditions that I don't touch on, please feel free to stop me and we can just talk about them and talk about what you would see. Because in reality, a lot of these conditions we will already be on board by the time that imaging comes back or whatnot. So at that point, we may take over, but it's still important for you all in your practice to recognize things like this when you're in out in the community, or whether a family calls you for advice and you need to know what to tell them before they have a surgery consult or before they get to the ER. So no disclosures. I won't go into my background as people normally do, but these are some of the conditions that we see in pediatric surgery, and that's one of the reasons that pediatric surgeons like what they do, because there is a very wide variety of things that we see. So the things that I put in red are conditions where you will a lot of times have an emergency and that we need to get on board right away. Some of these more than others, and some will be much more sick. For instance, a pyloric stenosis. Is it a surgical emergency? Well, no, not necessarily, but you do need to know how to resuscitate these kids, because if you don't, they can become very, very lethargic. And on the back end of after their surgery, they can require intubation. They can be difficult to wake up from surgery. And so while that may not be a true emergency, I did include it just briefly here. Um, the most common thing that we see in the NICU is neck. So I didn't include it in this presentation just because I know you don't see it a lot on the floor, but just remember, anytime, especially in preemies, these children are susceptible to getting necrotizing enterocolitis, infection of their intestines, whereby they get sick very, very fast. So if you ever see a little baby that has a reddened belly or an acute change, the first couple of things that you want to think of are NG tube decompression. This is more in the hospital setting. Get an x-ray just to look at their belly and you're looking for pneumatosis or portal venous gas. Those are the buzzwords to get us to come right away, especially portal venous gas, because 99% of the time those kids need to be operated on right away. The kid that I'm going to XLAP now has a stricture from neck, had medical neck, and was treated with antibiotics, and we weren't really involved during that. Seems to have had a stricture and is intermittently vomiting. Contrast studies didn't show that necessarily from below or above, although the kid has not progressed. So my plan was to XLAP the kid tomorrow and see what the stricture it is and possibly put him back together. But the kid is decompensating for unclear reasons. So this is probably not related, but rather than sit on him till tomorrow, I'm just going to go ahead and XLAP him today. Hirschsprung's malrotation volvulus, those are sort of the main ones, and intussusception. So I would say those are the important ones for the infants and toddlers type age. So we'll discuss some of these conditions, and then we'll go over a little bit about how you would recognize them and how you would treat them. Okay, so malrotation. So before we get started with that, we frequently get called and say that patients have concern for volvulus. And a lot of times that word is used very, very loosely. So malrotation in and of itself is not a surgical emergency. All malrotation indicates is that the baby is not rotated as we all are, okay? If you say malrotation with volvulus, that is a surgical emergency. So try not to mix up the terms whenever you're consulting for this condition, because they are managed differently. If I got a call right now and I'm on call in a baby with malrotation that is well appearing, I don't have to rush to the operating room today. I can do this tomorrow. If the kid is volvulized, obviously you have to go to the operating room immediately. So occurs anytime you see something that's common in pediatric surgery. It's usually 1 out of every 5,000 or 6,000 live births. And most of them will present within the first week of life, more so within the first month, and large majority within the first year. You see some numbers there. Some people will say 1/3, 1/3, 1/3. So 1/3 in the first week of life, 1/3 in the first month, the other third in the first year. You can't have people that present later in life and people that present really late in life. I think the lead singer of the Bee Gees died from malrotation with midgut volvulus. So obviously was not diagnosed till he was, I think, in his 60s. So as I said before, malrotation is when your intestine does not rotate correctly. And we'll go a little bit into what that means. I'm a visual person, so I like to see pictures. It helps me conceptualize things much better. So it usually occurs around the 10th week of pregnancy. Okay, so we always talk about the ligament of Treitz or the duodenal-jejunal junction, the DJ or the DJJ, failing to cross midline. The DJ junction lies inferior to the duodenal bulb, and then you get a lateral view that shows your duodenum is not going retroperitoneally. Okay, so when we ask for an upper GI, we're looking for those three things. You want to see it cross midline, you want to see it come up to the level of the duodenal bulb, and then the reason they do a lateral is because you want to make sure that the duodenum goes posteriorly towards the spine and that it's retroperitoneal. If all of those things are present, you do not have malrotation. You have sometimes a condition where it does cross midline and it does go retroperitoneal, but it doesn't come up to the level of the duodenal bulb. That's somewhat been classified as a varying degree of malrotation, but that's pretty rare that you see that. And all of this comes about because there isn't a 270-degree counterclockwise rotation around the SMA. Okay, so you see in red and green. Okay, so the way that I visualize this is your cecum, your cecocolic loop in green. You start, can everybody see my mouse when I do this? Yes, no, maybe?
Yes.
Okay, so you start down here and you think of your cecum, and this is your SMA. So you all think of it as a clock or an axis. Your cecum, your appendix comes off of your cecum. So your appendix is in your right lower quadrant. So let's imagine this is your belly button, even though it's not, it's your SMA. And you imagine this is the right lower quadrant. So this is how I visualize it. It starts below the SMA and it does 3 separate 90-degree turns and it ends up in your right lower quadrant. That is where your cecocolonic loop ends, okay? By contrast, your DJJ, your ligament of Treitz, your duodenal-jejunal loop, whatever you want to call it, starts above your SMA and it does a counterclockwise rotation and it ends up to the left of the SMA, to the patient's left of the SMA. That makes sense because your ligament of Treitz is crossing midline. It's left of the spine, okay? So that's how it ends up here. So anytime you don't have this degree of rotation, that's where you end up with a condition called malrotation. This just shows a little bit of the time and timing of it again, how you rotate around your SMA. And again, this is somewhat just showing what I just talked about, where you have separate 90-degree turns and eventually you end up in your position. And so this last picture just sort of focus on this. You see your stomach comes here, your stomach comes around, it goes over to your duodenum, it crosses back midline, and then you get your ligament of Treitz right here. And then your small bowel kind of goes all over the place, okay? And if it doesn't do that, then you have a variant or just, straight malrotation. And that was your cecocolic loop, the same thing. Your cecum ends up in a right lower quadrant down here, and then you have your appendix in the right lower quadrant. So up to a third will present with midgut volvulus. Again, this is where you call and you say, we have midgut volvulus. If you have midgut volvulus, one of two things has happened. You have either proven that with your upper GI, or you are very, very concerned that this patient has an acute abdomen. Please, please, please remember bilious emesis and malrotation until proven otherwise. It does not mean you have midgut volvulus, but it is malrotation until proven otherwise in a little baby. I got called from the ER, it was probably 9 months ago or a year ago, and I was down there for another reason. And there was a little baby, a 3-week-old with bilious emesis, and they were getting a pyloric ultrasound, and that made 0 sense to me. So if you have bilious emesis, your first inclination is that you need an upper GI to rule out malrotation, okay? because if you don't, that patient can volvulize and can lose all their intestine. And the rest of the stuff is pretty self-explanatory. Okay, so you may start with the plain film, and that's perfectly acceptable. Start with the plain film, see what's going on, but then you have to go to the upper GI. And as I told you about, you're looking for the 3 things on an upper GI, okay? If you see corkscrewing, then that is malrotation with volvulus. You don't need corkscrewing to just show you malrotation. Remember, that shows you the volvulus. And so what you essentially have is, instead of this, where your small bowel is not fixed, except at your ligament of Treitz, your colon is always fixed. For those of you that don't know, so your colon goes up your right side, across, which is your transverse colon, down your left side, and out your poop chute. And your small bowel is all mixed in there. And this is what you will see when you have malrotation. So your cecum is not fixed in the right lower quadrant, and your ligament of Treitz, or your DJJ, instead of coming across midline over this way, it goes straight down. Okay, and this part, like a cauliflower stalk, if the stalk is very narrow, it can twist on itself. If the stalk is very, very large, like a sheet of paper or some broad-based mesentery, you're less likely to volvulize. But when it's in a thin, narrow stalk, that is where you're susceptible to twisting on that stalk. So another way let's just say your upper GI was not, it usually tells you yes or no, but let's say you didn't have any information off the upper GI. You weren't really sure. Can you do a contrast enema to rule out malrotation? The answer is yes, right? Could do it because it could give you an idea of where your cecum is. If your cecum is not in the right lower quadrant, that's going to be malrotation. Okay, if it is in the right lower quadrant, that doesn't mean you don't have malrotation. Okay, you can get fooled, and this can still be over here somewhere. It just may not be fixed to the sidewall. This is fixed. So your colon is fixed over here and fixed over here, okay? But it's not in these. So this is showing you Ladd's band. So in general, you are fixed here on your colon, your right colon, you're fixed on your left colon, okay? You're not in malrotation, but you do have these Ladd's bands that attach your colon over to the sidewall. And what do these bands do? They obstruct this duodenum right here. When they obstruct this duodenum, that's why you get backup of fluid, and that's why you get bilious emesis, okay? So you can still have bilious emesis without twisting of the intestine because you can still have an obstruction here causing it to back up. But the bilious emesis can also be because this twists and has a functional blockage, in which case you're going to have backup of stuff and have bilious emesis. All right, so just some pictures. So is this kid volvulized? No, this kid is not volvulized, or actually this is a 39-year-old female, but for conceptual purposes, this patient is not volvulized. So stomach is very distended here, okay? You have your esophagus coming in your stomach. Your antrum goes into your pylorus, and you have your duodenal bulb right here, okay? Then you do your C loop, which goes retroperitoneal, and it comes up to the level of your duodenal bulb. So this right here is your duodenal bulb level. So you want to see it come up and then back down. If it comes over, but just kind of stays low, that can be a variant of malrotation. So this does come all the way up. So you have 1 check mark. Number 2 check mark is it crosses midline. And then the 3rd check mark is, does it go retroperitoneal? And you don't know because you don't have a lateral view. This is your lateral view. How do you know it's a lateral view? Because you see the spine right here, okay? So your spine is on the right of the picture, not straight up and down. So you see the duodenum going retroperitoneally here. So this is a normal upper GI. Okay, so this is kind of what I said. Okay, so this on the left side of your screen, you see the small bowel spiraling and going straight down the right side. Okay, so this kid is malrotated. Right here, you see malrotation, right? This intestine is not twisted, but then the intestine twists on its narrow mesentery. And this is what causes your volvulus. So this will progress pretty rapidly. You'll get hypotension, decreased urine output, abdominal distension, peritoneal belly. This kid needs to go to if you ever see a picture like this where it swirls, that is an immediate consult. And that is a you come in and operate right away. You don't sit on it. So surgery involves 4 things. You get rid of these Ladd's bands. Okay, so that relieves the obstruction. you have to widen the mesentery. So remember I told you you're more likely to volvulize if you have a narrow piece of broccoli or a narrow piece of cauliflower. The further you can splay out that stalk, the less likely it will be to recur. Okay, but it can recur. So you have to widen out that mesentery. We take the appendix because you leave the colon on the left side and the small bowel on the right side because that's where it wants to be. So because in the old days when they went by physical exam more than imaging, you took your appendix. If you did not take the appendix and you put the colon on the left side, the patient had left upper quadrant pain, people wouldn't think of appendicitis. Now everybody gets a CT scan, so it's not as pertinent as it used to be, but we still take the appendix. And then this is kind of a wrong statement here. So you don't place the bowel back in correctly. You don't twist it. You place it back in with the mesentery flat so it doesn't twist, but you put the small bowel on the right and the colon on the left. So the orientation of the bowel is not like yours or mine. So occasionally we've gotten a call saying a gastroschisis patient is malrotated. Well, yes, all gastroschisis patients are malrotated. That's not an issue. Diaphragmatic hernias, they're malrotated by nature. Their intestines did not form correctly. But if you have a volvulus, mortality, it can be extremely high and it can come back. So I mentioned these before. These are the diseases associated with malrotation. You don't always do something for it. So whenever we fix CDHs, we tend not to mess with the bowel at that time. Now, these babies are malrotated, but as long as they have a broad-based mesentery, we know that they're malrotated. The chances of them volvulizing are pretty slim. So you don't necessarily fix the malrotation. You make it less likely that they're going to volvulize, but they always stay malrotated. You can't fix what's not fixed to begin with in terms of fixing the intestine. Okay. Any questions on that before we move on?
Dr. Bala, will they always get the lateral on the upper GI, or is that something you have to ask for?
They always get it. So they know to do that. So it's a good idea too. That's a good point. So when you look at your films, just make sure next view that you look at, just look at the upper GI when you see that they're malrotated, and you'll always see a lateral film. Whether or not they upload it and impacts is another thing, but they will always look at it laterally. So intussusception, another one you'll see pretty frequently, the most common cause of obstruction between 3 months and 3 years of age. It's a little bit higher incidence, obviously, than malrotation. And you can have certain conditions that predispose it to you, but the majority are idiopathic. And ileocolic is the most common. So vomiting, abdominal pain, current jelly stools, to be honest with you, I can't remember the last time I actually saw current jelly stools, but that's, your buzzword for your test. And it can be from a couple of different reasons. Usually the patients have some sort of URI beforehand or GI bug beforehand that causes it. And they get severe colicky pain. They don't always draw their legs up as you read, but it's just inconsolable pain. So if a kid comes in obstructed and they're in the toddler age range, your first thought, especially if they don't have bilious emesis, your first shot should be an obstruction secondary to an intussusception. So you're not rushing off to an upper GI in that case. You're doing an ultrasound to look for a target sign. The older kids, you have to think about lead points. So if that age range, when I mentioned 3 months to 3 years roughly, if there's an older kid, let's say you call me for a 6 or 7 year old with intussusception, the red flag should go off in my head. That kid may have a lead point causing it. And that can be a Meckel's. It can be as simple as a lymph node from a recent URI or GI bug. But you have to think about, other things like tumors. And that's rare that you see the other things. But, especially if you get it reduced in an older kid and it recurs, this is where the age comes into factor. So let's say I have a 1-year-old with an intussusception. And they call me in the middle of the night and the radiologist is able to reduce it. And so I go back to bed, they get admitted to you. The next morning they call and they say, I'm concerned again. I just got another ultrasound. There's another intussusception. I'm going to say, go back to radiology and get it reduced. It happens a third time. Some of my partners would take it to the OR the third time. I may or may not. I may say, go to radiology one more time, get it reduced. And if they can, great. And if they don't, fine. And I can guarantee you, if you call me the fourth time, I'm going to the operating room. So there's no hard and fast rule on how many times you're going to let it happen before you go to the operating room. So your first call to us after they've been reduced should probably be, I'm very concerned, they have colicky pain. I've already ordered the ultrasound and gotten that process started. If you tell me the kid is 4 or 5 and they've been reduced and they have it again, I'm probably going to go to the operating room the second time, because if they're out of that age range, I need to make sure that they don't have a lead point, and you can't assess that if radiology does all the reductions. So this is how you visualize an appendix. So an intussusceptum goes into the intussuscipiens. So like the recipient, intussuscipiens, that's how I remember it. So your small intestine goes into your colon, okay? And your colon actually can start to eventually invert on itself also, and your appendix can get trapped inside this, which is often the case. But you see how your small bowel goes into your colon, okay? Ileocolic being the most common. So the idea here is, if you look at the bottom picture, when they do the air enema, they're going through the bottom, they squirt air, and they're trying to push this thing back out to normal. Okay, that's why they do it from the bottom. So your small bowel telescopes into your large bowel. Of course, you can get ischemia, your blood vessels get irritated, edematous, then they start bleeding, and that's called your current jelly stools. If this goes on long enough, it can progress to bowel compromise, which can give you septic shock, and in theory, it could lead to death. If the patient's gotten that far in a first world country, then something has been missed, or the parents have neglected the child. But in general, we see it. Normally, we see it when it's just been going on a day. Occasionally, it's been pain for a couple of days that the parents just thought was a GI bug, and the kids were inconsolable. That bowel has a tendency to be compromised, or it's just near perforation, and when you reduce it, you obviously risk, because you have to squeeze pretty hard sometimes, you can risk perforating it, and you have to make the decision, if it's not perforated, whether or not you take the bowel out, and that's often not a fun decision. I had one actually 2.5, 3 weeks ago. Of course, all these are in the middle of the night, so I left the kid at about 2 or 2:30 in the morning, and it had been going on for 2 or 3 days. It must have been somewhat intermittent, and it was very, very hard to reduce. A lot of times now we'll do this laparoscopically, with it being 2 or 3 in the morning after a big trauma that had come in. I just chose to do it open, because you can do it through a very tiny incision around the belly button. And it was very hard open for me to even reduce it. So there's no way laparoscopically I would have been able to, just by pulling or tugging. And when I finally did get it to pop open, the bowel was very, very, very ischemic. And so I let it sit for 10 or 15 minutes. And even then it pinked up, but it wasn't quite normal. And I made the decision to leave it and close. And, it took a day or two before you really start to relax when the patients do better, because that can progress if it doesn't reperfuse well, and it can be necrotic. So you have to make that decision when you're in the OR. This is another picture to kind of just showing you, I've already shown you, but it essentially causes a bowel obstruction. So what are you looking at on the ultrasound? You're looking at a target sign. That's pretty classic for it. And then in your air enema, like I said, air contrast enema, air enema, depends what they want to do. But essentially, you're trying to use air and pressure to push this small bowel back and pop it open. And a lot of times they can get it wherever the intussusception is, whether or not it's in the transverse colon or even the left colon. They can get it all the way over to the transverse colon and usually down the hepatic flexure. But sometimes they can't pop it back from the ileocecal valve. So that's where it gets stuck, and then you have to operate. If it somehow gets past an ultrasound, i.e. maybe people weren't thinking about that as the primary and found it secondarily, and you get a CT scan instead, you'll see this on the CT scan. So you'll see a little target sign on the CT. And this, again, we see ultrasound. So you see the difference in the bowel and the outer loop of the bowel and the telescoping within being hyperechoic. Ignore this part. I don't do this anymore, and some people may still do that kind of incision because it's ileocolic. So you would think you make a right lower quadrant incision that's right there for cosmetic purposes. I don't like to do that. So I make a tiny incision around the belly button because you can hide that much better and eviscerate the bowel. You have to pop it open. Sometimes you do have to tug pretty hard to get it to open up. Of course, you don't want to perforate it. And it's a small chance of recurrence. So we'll always keep these kids. I mean, we keep them anyway, but you want to make sure the next day they don't have recurrence of their symptoms. And we had one recently that my partner had to take out bowel and reanastomosed because there was bowel compromise. If it's, to be honest with you, if it's during the day or even at a reasonable time at night, laparoscopy we've done many times. It is a viable option, but in the tiny babies with such a small incision that you can essentially hide, trying to fight the OR with laparoscopic equipment in the middle of the night is sometimes more trouble than it's worth. So depends who's doing it, how aggressive they want to be in the middle of the night. And, you know, results aren't always, of course, we don't see the ones that we don't see, right? We see the ones typically that we have to operate on. But if something's going to recur, it'll recur within the first couple of days. And you can see the numbers there for one recurrence versus multiple recurrence. Again, I give it at least 3 times. Third time, depending upon their age, you may convince me to go to OR. Otherwise, I'll give it one more shot. This is not our protocol. This is the protocol at Children's Hospital of LA, but you can kind of see what they do. Just one thing I wanted to point out here is just make sure these patients are resuscitated. So if you all get, I know the ER does a lot of this, but if you all get called for some reason and you're managing this instead of the ER, don't forget during all of this point, the patients need IV fluids. A lot of times we'll see an appy, we'll see a pyloric, we'll see somebody in the ER, and with everything going on, there's never been maintenance fluids or anything like that hanging during all these tests. And I understand people get busy and orders don't get put in. Just these patients are already volume behind. So where I trained, where I did my critical care year in DC, everybody got twice maintenance for a nociception. Doesn't matter how long they had it. When they came in the ER, they got it and they started it and they kept it all night. I don't know if you necessarily need twice, but I certainly, when I admit mine post-op, I run them at 1.5 overnight. And sometimes even into the next day, just because they're always volume down. So you can give a bolus in the ER for sure. You're not going to hurt anything. If it's positive for intussusception, they're already volume behind. Any questions on intussusception? Okay, so Hirschsprung's disease is not a surgical emergency, with the exception of one situation. So I'll briefly kind of touch on it. I'm not going to go into the surgical management of it because that gets very complicated and is not really in the scope of this week of your studies. But you all know Hirschsprung's disease can vary anywhere from total, colonic Hirschsprung's to parts of the colon, and it essentially causes a bowel obstruction type physiology. Most cases are sporadic, although if you have a sibling, you can have another sibling with Hirschsprung's disease. So short segment versus long segment. Short segment's just limited to the rectosigmoid. Obviously, long segment is a lot bigger, and it's rare to have total colonic aganglionosis. That's a big problem. But when they present as a bowel obstruction, they can present with some of the same symptoms that you see everywhere else. So bilious vomiting, abdominal distension. You want to know if the patient passed meconium in the first 24 hours of life, because that may tell you. Can they pass meconium and still have Hirschsprung's? Yes. I mean, we've been fooled by moms telling us yes or no, but at the same time, that can give you a big tip off if they did not. If they get large enough, they can perforate. But this is really the main thing that you need to know. So enterocolitis can be a life-threatening emergency in a patient who has had Hirschsprung's disease. So after they've been repaired, after they've been fixed, if they come to the ER, they come to your practice and they are having profound diarrhea, fevers, lethargy, they need to get to the hospital. They need to be treated with antibiotics, which is usually Flagyl-based, and they need to have rectal irrigations and IV fluid resuscitation. So do not let a patient with a history of Hirschsprung's disease with any of these signs or symptoms go home from your office. Make sure you call the hospital, call the surgeon, call who you need to call, but don't treat their diarrhea and symptoms the same as you may somebody else who's completely healthy who just has a bad GI bug, because this can be life-threatening in these Hirschsprung's kids, even after they are fixed. So we get contrast enemas to look for a transition point. And so what you're looking for in the contrast enema in Hirschsprung's is your rectum is always bigger than your sigmoid, right? Because we can all hold poop before we have to go to the bathroom. So we have a rectal vault. In patients with Hirschsprung's, their cells don't go all the way to the end. So they get more dilated because they're pushing, trying to expel this stool. So you have an inverse relationship between your sigmoid and your rectum. You can see here, this is much larger than this. Okay, so this is your transition point right here. So that's suspicious for Hirschsprung's, and that patient needs a biopsy. So for Hirschsprung's, yes, you need a surgical. Now, this isn't an emergency. You don't need an emergent surgical consult. This is more for if they have enterocolitis. And for standard Hirschsprung's, you don't have to do antibiotics right away. It's really for the enterocolitis that you do. So pyloric stenosis, again, it's not really a surgical emergency, but it's something that you all should recognize immediately and resuscitate them appropriately, because if you don't, these babies can be very lethargic. I've seen them get intubated. I've seen kids come in with CO2s that you wouldn't believe that have to go to the ICU, and it is days before we can operate on them to get their labs somewhat normalized. So if you, and this is a type of patient you probably see more in your outpatient practice for those of you going into just gen peds, than any of the other ones I previously mentioned, because a large majority of that stuff is found in hospital settings. But just remember, these patients, similar to the intussusception, they are always volume down because they've been throwing up for days, and you guys have tried formula changes, and 99% of the time that's worked, and the 1% when they have something else going on, it hasn't worked. So they come to the hospital with frustrated parents because they've made all these changes, and so we try to tell them, well, listen, for every kid that it works on, for every 10 that it works on, you're the ones that it didn't. So the pediatricians did the right thing and tried formula changes and milk proteinology and all that other stuff, and there was something else going on. But you can't ultrasound every single patient who has any sort of emesis, or you'd be ultrasounding the entire baby population. So this is what we use in my fellowship. We don't necessarily stick to it here, but this just goes to show you when their electrolytes are this out of whack, how many boluses they actually need. And then we also run them at maintenance and a half. So they're already pretty volume behind. So you're never going to be faulted in a patient with pyloric stenosis if you go ahead and start a bolus. And then reassess their labs. So the first time we instituted this protocol, we had nurse practitioners overnight, and the fellows took call from home, and they didn't necessarily recheck labs as often as they should. So instead of getting rebolused hours apart with recheck of labs, the patient got like 140 per kilo the first night or first 24 hours of fluid. That was way too much. So once we do fix them, I feed 2 hours later. And when they don't throw up, twice in a row, I let them go home. So usually that's day one. Appendicitis typically is not a surgical emergency, with the exception, you'll probably see 1 or 2 while you're here at most, where these patients come in perforated and they are peritoneal and sick from perforated appendicitis. So anytime you have an unexplained acute abdomen or peritonitis, perforated appendicitis should always be in your differential. I've seen it as young as 2 years old, but more so the older population, or older than that, a few years older than that. So these kids can get very sick. And as you all probably know, when we see an appy, if it's 5 days or less of pain, then we typically go to the OR. Even if it is perforated, you just deal with all the pus. After about 5 days, you start to get phlegmons or abscesses starting to form, and it's just a mess in there. So you try to manage those with antibiotics, IR drains, and take out their appendix 6 weeks later. That is called an interval appendectomy. But sometimes you can't do that. So if a patient comes in, they've been having abdominal pain for 7 days, we CAT scan them. They have abscesses, which are well formed. I would normally treat those with interventional radiology drains, but they are just peritoneal. They have to go to the PICU. Their belly is distended. They look awful. Sometimes you have to take those patients to the OR and wash them out and get source control. Again, that's not going to happen very often, but you will see it. So you get a tissue edema process, necrosis, and then the kids perforate. It really is a great masquerader. So sometimes you won't have that in the back of your head, and you'll be thinking about all these other conditions, and it actually is just perforated appendicitis. And it's really, really hard in little kids because they don't tell you. Here's some of the other things that it can be. I suppose you all may actually see ovarian torsions too. Same with testicular torsions. That's a similar process where it needs to go emergently. Everything else shouldn't be, unless it's a perforated Meckel's, shouldn't be an acute abdomen. You shouldn't have to rush to the operating room, other than large bleeding from ulcerative colitis. I guess that's another. And I kind of told you the decision operates, a lot of it's based on timing, as long as the patient doesn't look toxic or septic or in shock. Obviously, if they are, then you have to go to the operating room and get source control, because antibiotics alone are never going to change the outcome of that. But if they're not in shock, then you try to hold off if it's been, rough 5 or 6 days or more. My limit is 5. So if it's 5 or less, I go to the operating room no matter what. If it's more than 5, then I try to treat at interval, but that does depend on the CT and how well the abscess is formed, because you can't always rely on patient history. Symptomatic cholelithiasis is never an emergency. Cholecystitis can be. You need to bring them into the hospital, cool them off, and then take out their gallbladder. Same with gallstone pancreatitis. For you all to know, gallstone pancreatitis, the gallbladder should come out before they leave the hospital. So don't ever send a patient with gallstone pancreatitis home until we have seen them and we've taken out their gallbladder. So really it's the secondary effects. Some of this other stuff is just biliary dyskinesia and gallbladder disease. But the important thing to remember of gallstones or gallstone pancreatitis or any of that, gallstone ileus, is they can get, if they get obstruction of their common duct, they can get an infection, they can get pancreatitis, but they can also get cholangitis. And cholangitis can be a medical emergency, as you know. So always have that in the back of your head. Make sure you look for Charcot's triad, all that sort of stuff. We probably know all about this. So your studies would typically be an ultrasound. If we get involved, for a lot of times for biliary dyskinesia, we do HIDA scans. So again, it's the same with everything else. You're going to do IV fluid resuscitation, antibiotics. That's what we always start with in the infectious conditions. Necrotizing colitis, you want to do that. Appendicitis, you want to do that. Gallstone disease, you want to do that. And then once they're resuscitated, get them to the operating room. And I think that's it. Is there anything else that you all wanted to talk about that we have not talked about?
Gabrielle has a question.
Okay.
I wrote it down, dang it. What made the enterocolitis, I think it was it was Hirschsprung's. What made the Hirschsprung's patients more susceptible to enterocolitis and bad side effects?
Yeah, so a lot of these patients have intrinsic problems with their intestines. It's the same with the anorectal malformations. So even after you fix an imperforate anus, they can still have diarrhea, constipation, bowel issues. It's the same with enterocolitis, Hirschsprung's. Even though you have pulled the bowel with ganglion cells down to the rectum, you can still have stasis that sits in there and bacterial translocation. And so anytime that you have a buildup of stuff and you have bacterial translocation, they are very susceptible to that process. And so that translocation can make them very, very sick.
Thank you.
Yep. Okay, you'll enjoy the rest of your lunch. Thanks.
Thank you, Dr. Bala.
Thank you.